All right. So UTIs, so these are infections of your urinary tract. It's one of
Your
the most
screen is
common.
black. Oh,
What
never
was
mind.
that?
It's up now. It was
Is
black.
it working now? Oh, okay. You can see it though now. Yeah, okay. So one of the most common things, infection-wise, that happens with kiddos, usually more common in girls than boys, okay? But if that child is a boy and is not circumcised and they're less than 3 months of age, then that's when they're most at risk for getting a UTI. Okay, because parents aren't cleaning, around their foreskin and things like they should be. That's the most common time period that boys who are uncircumcised get UTIs. Otherwise, mostly girls. Usually, a lot of times it's related to they're not wiping the correct direction, okay, or they're not wiping fully, or they're not urinating and emptying their bladder completely, okay. Making sure that these kids are finishing all of their antibiotics is very essential, um, just to continue to reduce the risk of having, kidney involvement and things from infection. Okay, how do you diagnose UTIs? You have these kiddos do a UA. Now, if they're older and they can clean and do a clean catch, even if they can clean with parents' help, then that's okay. You can do a clean catch urine. If they're an infant, though, and you're suspecting a UTI, the preferred way to do that is by catheter. Okay. So straight cathing these kiddos. Okay. So if you have a child who is not fully potty trained, and they can't try to go on the potty, then that would be the route that you would need to go, is doing a straight cath. Some other findings that may be suggestive of a UTI is obviously strong foul smelling urine, cloudy urine, kids having more frequency or urgency, them complaining of pain or burning with urination, just like, similar symptoms to an adult with a UTI. Prevention of UTIs, making sure that they're wiping from front to back if they are female, making sure that they are emptying their bladder totally, so sit on the toilet or urinate completely every time they're going to the toilet. And then if they're adolescent females and they're sexually active, making sure that they're urinating shortly after, as soon as they can after intercourse. Okay. So when you're diagnosing a UTI, you not only will do a quick UA, but you should also send the urine for a culture to look more closely at it, because sometimes your UA is going to come back positive with some white blood cells or leukocytes on your UA. But that doesn't always necessarily mean for sure that these kiddos have a true UTI. It may be that they didn't clean as well. So when you send that urine for culture, they will watch the urine just like they do with like wound cultures or blood cultures. They'll watch the urine for a period of time and see what it grows back. If it grows something back, then they'll give you a sensitivity to see what that bacteria is sensitive to, what can kind of treat it, to make sure that the antibiotic that the kiddo's on is going to treat that type of bacteria. Okay. Sometimes suprapubic aspiration, so actually going in to the suprapubic area with a needle to aspirate urine is an option. Also kidney taps, so through the skin, tapping into the kidney, that may be also another option for UTI diagnoses. Looking at ultrasound, you can see if that kidney is involved in the infection. So you're dealing with more of a pyelonephritis versus just a UTI. Making sure that the kidney itself and the ureters and all of that are looking like they should. A VCUG, so this is actually when they void, so they're gonna void, and then a camera is inserted, or they do it with ultrasound through their urethra, and they kind of see how everything is working when they're voiding and that they're emptying their entire bladder. Okay. IV pyelography, this is where they insert some dye and they look at the kidney filtration with the iodine dye. Okay, and then you can always do a renal scan as well. So external deficits of the GI tract phimosis. So this is the narrowing of that opening of the foreskin. Okay. So this can be a normal finding for some kids as long as it's not a significant form of phimosis. So if it's like type 4, that's going to need to be addressed. Okay. Because these kids are going to get balanitis, so they're going to get infection and inflammation of the foreskin often if they are severely affected with the phimosis piece. Okay. Usually as they go through puberty, if it's like a type 1 type of phimosis and it's not causing pain and they're not getting balanitis often, then they don't have to have a circumcision. Okay. Phimosis can be managed with a steroid cream, especially if it's like type 1 or type 2. Usually that's enough to kind of get that foreskin to relax. And then it resolves. Okay. But like I said, if they're an extreme case of type 4 and you try a little topical steroids, then it's not improving, then they'll need to have that circumcision. Okay. Management of kiddos with phimosis, making sure you're talking with parents about and the kiddo about making sure that they're cleaning this area very well so they're not getting that infection, that balanitis. And not to forcefully pull back on the foreskin to try to resolve the phimosis. By doing that, you can cause a lot more trauma. So telling parents not to forcefully pull back. Paraphimosis can occur. So that's further edema and venous congestion in the area where that narrow opening is occurring. And this is a urologic emergency if they're having paraphimosis. So if there's increased swelling with the phimosis, then they need to be seen right away. Okay, hang on, I have a chat. Let me look here. Taylor Mosley, I wonder if it's from your, I don't know if your internet's not working right. I know a few of you guys have messaged me about your internet issues, so keep trying. If you have to log off and log back in, you can. Okay, so external deficits of the GI tract hydrocele. So this is fluid in the scrotal sac, usually peritoneal fluid. So it's coming from, the abdomen peritoneal space and kind of then surrounding the testicle. So this kiddo will have an enlarged scrotal sac, and you'll kind of feel, it'll be harder to feel the testicle. Usually this is fairly common until about 12 months of age. And as long as it goes away before 12 months of age then they don't need any intervention. But if it's still occurring after 12 months of age, then they'll need to have some sort of intervention, so surgery, to remove that fluid. Okay. Initially, when they have the hydrocele, especially after they've had surgery, there'll be temporary swelling and discoloration, but that should resolve as they heal from surgery. You don't want to have any risk of that area, that hydrocele reoccurring. So straddle toys should be avoided for 2 to 4 weeks, and then the child can bathe about 3 days after the intervention. Okay. Cryptorchidism. So this is the failure of one or both testicles from descending. So there's different categories. There's abdominal, canicular, and ectopic. So abdominal would be, you know, the more of a true cryptorchidism, which that's within the abdominal cavity. Okay. And ectopic is going to be, it's depending on the location. You can have a femoral in the femoral location, so kind of in the area of the femoral artery. You can have your testes be there. Your testes can be more superficial and in the ectopic area. Pre-penile, so it can be kind of above the penis, or it can be, you know, higher up within the scrotal sac. Okay. You will see, like I said, an increased risk of testicular cancer in kids who have cryptorchidism. You can also see a complete absence of the testes, which is anorchidism. Okay. There's potential to decrease fertility rates, but usually once they have surgery to have that testes put in the correct spot in the scrotal sac, then usually fertility should return. Okay. And you find this by typically not being able to palpate a testes on your exam. Okay. Or you know, your male patient could come in and say that, you know, their testicle is no longer palpable, or parents may notice that too in an infant. Okay. Sometimes after they have surgery to correct it, sometimes it can happen again as well. Okay, so hypospadias. So this is the abnormal urethral opening on the ventral, so the underside of the penis. Okay, it can be mild or it can be severe. So severe would mean that the opening would go essentially the whole shaft of the penis all the way to the scrotal sac. Okay. Like we talked about in the cahoots, we do not have these kiddos be circumcised because that foreskin tissue is going to be what's utilized to do the correction surgically. Okay. Surgical correction is usually done between 6 to 12 months. Okay. And they may have caths for a period of time after post-op to just kind of keep that urethral opening that they've created open. Okay. You obviously get concerned, just like with any surgery, with infection. Okay. Extrophy or epispadias. So this is defect. It can involve potentially the muscles, musculoskeletal, the urinary, reproductive, and intestinal tracts. Epispadias is exposed urethral opening on the dorsal side, so the top portion of the penis. Okay, so you can see that here. So a complete epispadias, like I said, would be from the head of the penis, the glans penis, all the way back through the shaft of the penis. And then penile epispadias would be, you know, within the portion your urethral meatus is, you know, somewhere along the shaft of the, or the dorsal side of the penis. Okay. Bladder extrophy, that's when your bladder is open to the outside, so the abdominal cavity. And colloquial extrophy is where the bladder and the intestines are with outside of the abdominal wall. Okay. And this typically happens fairly early on in embryologic development. So like within the first 8 weeks, usually. Complex epispadias, this is going to include the extrophy as well for the bladder. They can have kind of a combination of extrophy of the bladder and epispadias. That's usually how you see it. So they're going to have both the bladder outside of the abdominal cavity and then the urethral meatus opening on the dorsal side of the penis. If this isn't treated fairly quickly after birth, then you very much are concerned about renal damage and infection. Okay. Keeping this area moist and covered until surgery is going to be really important. Okay. They do the surgery in stages. So usually they place the bladder within the abdominal wall first and suture that. And then they look at addressing the epispadias. Okay. Making sure you're talking with parents about preventing UTIs and, you know, these kiddos, as they get older, they're going to probably be self-conscious about their scarring, and making sure that you're preserving their renal function. Okay. And talking about the potential of troubles with continence and sexual dysfunction. If it's addressed early, then usually you don't see the continence issues or the incontinence issues or the sexual dysfunction, but still a potential to talk about with parents. Okay. Limiting the trauma of the area that's been sutured and worked on. Monitoring I&O. Okay. Monitoring for signs of infection, pain management, and then keeping that that catheter in place or working with that patient on self-cathing if they're needed. Okay, and supporting the kiddo and the parents. Okay, renal biopsy, your responsibilities as a nurse after a kiddo has a renal biopsy. So these kids cannot eat or drink for 4 to 6 hours prior to having the renal biopsy. You're going to set up for the procedure. So this will be done under ultrasound. It is sterile. Okay, so you will be working with sterile fields. And then you may be assisting with the procedure as well as pediatric nurses. You'll be monitoring vital signs, making sure your kiddo is staying stable while they're working on the renal biopsy. After they have the biopsy, you will be applying pressure, usually trying to utilize a sandbag, unless of course it's a tiny infant, you can't use a sandbag, but you'll just have to apply pressure to the dressing. And the amount of time that you will apply pressure to the dressing will vary based on your protocol or your policy of wherever you may be potentially working. These kiddos are going to be in bed rest for 24 hours, and then you're looking for abdominal pain, tenderness, or, you know, issues with output. Okay. If they're doing a biopsy on an infant, a lot of times they'll have to have a true surgical incision instead of just having the biopsy needle through the flank. Okay. Obstructive uropathy, so this can be structural, so there can be a structural abnormality, or there can be a functional abnormality, so something's not working the way it should. Okay. Backup of the urine causes obstruction and then leads to hydronephrosis, so leads to inflammation of the kidney. Okay, can be one side, both sides, it can be totally complete obstruction, or it could be a partial obstruction. Okay, diagnosing this early is really important. A lot of times they see obstructive uropathies when they are in utero, like having ultrasounds done. Okay. But of course, if a kiddo is not having enough urinary output, then you would get concerned that they have obstructive uropathy. Okay. So yeah, there's all sorts of hydronephrosis. Polycystic kidneys can be a form of an obstructive uropathy. Dysplasia agenesis, so a dysplasia within the ureter. There's all sorts of, so stenosis of the urethra, the sphincter not working correctly, stenosis of the ureter itself. There could be a band around the ureter that's causing the obstruction. Okay, or your uretopelvic valve could be narrow or not functioning appropriately. So those are all examples of obstructive uropathies. And like I said, usually they can see most of these on ultrasound while baby's in utero. Okay, nephrotic syndrome. So this is spilling protein in your urine. You're also wasting, your albumin is going to be low. You're going to have high lipids in the blood, and you're going to have generalized edema because of that protein loss through the urine. Nephrotic syndrome, so you're going to have a sodium restriction and fluid restriction. A lot of times these kids will have loss of appetite. They're at increased risk for infections, especially kidney infections. Okay. These kids will have activity adjustments because there's so much demand with the fluids and the edema they are experiencing. Supporting these kids like most likely will go home on oral steroids, so prednisone. So working with parents on things that they may see with a kiddo who's on prednisone and supporting these kiddos. So supportive care, like dietary sort of things, are your supportive cares along with your restrictions. So the goal is to reduce the excretion of the urinary protein. And then by doing that, then you reduce the retention of the fluid in the tissues. Okay. You really want to monitor these kids for sepsis concerns because of the potential for infection with nephrotic syndrome. And then very strict eyes and nose and daily weights. At the same time, naked or, in similar, just a gown. Okay. Good. Also, kids with nephrotic syndrome will be getting albumin replacement. Okay, acute glomerular nephritis. Okay, if you haven't ever seen strep throat, that's what strep throat looks like a lot of times. Okay, it doesn't always have to have this exudate, but a lot of times the tonsils are enlarged. The uvula is usually stuck to one of the tonsils too in strep. And then it's going to be their whole back of their throat is going to be really erythematous. Okay. So strep typically occurs 10 to 21 days after or before glomerular nephritis. Usually these kids are given antibiotics. They start to feel better after a few days, so they do not complete their antibiotics, and then they wind up with glomerular nephritis. Okay. So they're going to have oliguria, they're going to have edema, they're going to have high blood pressure, and they're going to have periorbital edema as well. Likely headaches, severe headaches. And these kiddos will need to be monitored really closely in the hospital. Okay. They're going to have blood in their urine. So they're bleeding in their upper urinary tract. And so they're going to have likely brown or red urine. Okay. They also have proteinuria and glomerular nephritis. So the more protein in their urine, that tells you that their glomerular nephritis is a lot more significant or severe. Okay. Almost all kids completely recover if they have glomerular nephritis as long as the strep is treated appropriately. Okay. Some have chronic kidney disease after having had the inflammation of the glomeruli or glomerular nephritis. Okay. It's pretty uncommon to have recurrences, but like I said, some kids have the chronic kidney disease. There does seem to be kind of an immune component. Like so parents who have had glomerular nephritis after having had strep throat, their kiddos might be more prone to it as well. Okay. Management of glomerular nephritis, daily weights, and accurate INO, those are going to be your priorities. Also, abdominal growths daily in kids with glomerular nephritis. Okay. They're going to also be fluid restricted and low sodium. And then, of course, you're still concerned about infections. Okay, Wilms tumor, nephroblastoma. Okay, we talked about this briefly during our hematology oncology week. So this is a malignant renal abdominal tumor. It's more likely in African American children. Typically, peak age of diagnosis is about 3 years, and it's more frequent in boys than girls. Causes, there's a variety of different causes. Not exactly sure why one kiddo gets Wilms tumor over another kiddo, but there are some potential genetic components. So what you'll notice is these kids will have abdominal swelling, abdominal pain, their belly will be distended. Okay. With Wilms tumor, you do not palpate the abdomen. Remember that, because that Wilms tumor, they're really sensitive and they can kind of flake off, and the tumor can then be more present than with that in the abdominal cavity. Okay. So no palpating the abdomen with these kids. That's your biggest thing. A lot of times these kids will have surgical removal of the tumor and then also radiation and chemotherapy. Okay, renal failure, acute renal failure. So this is an acute period of time. So there's a urinary obstruction or, glomerular nephritis or something like that that's causing acute renal failure. Okay. Chronic renal failure. So this is going to be a more long-term obstruction, or they're going to have long-term kidney disease that's caused them to have chronic renal failure, or they have a congenital anomaly like polycystic ovaries, or polycystic kidneys, that then is causing them to have chronic renal failure. Okay. So renal failure is the kidneys suddenly are unable to regulate the volume and the composition of urine. This is acute renal failure is not as common in children compared to adults. Okay, the usual reason is oliguria, usually from azotemia. It's going to also cause metabolic acidosis and then electrolyte imbalances if they have acute renal failure. Most common cause is from severe dehydration. Okay. So you get those kiddos that have like rhabdomyolysis and they have significant dehydration. Then you can see acute kidney failure with that. Chronic kidney failure, this is when more than 50% of the functional kidney capacity and renal capacity is destroyed. Okay. Usually it is a progressive deterioration over months to years. So like their kidneys continue to not function well for a long period of time. Okay. The clinical syndrome is uremia, is called uremia. Okay. So chronic kidney failure is when 50% of the kidney function is destroyed. Some causes in kids specifically, vesicular ureteral reflux from having frequent UTIs. It can be hereditary. They can have chronic pyelonephritis, so chronic kidney infections can then cause chronic renal failure. Chronic glomerular nephritis. Lupus can cause chronic renal failure. Or anaphylactoid purpura, so having anaphylaxis prolonged, causing the purpura to build up, and then that in turn affects the kidneys. And then also malformations or congenital renal abnormalities. So obstruction can cause chronic renal failure. So based on your pathophysiology is kind of how you're going to go about treating chronic renal failure. So if there's an obstruction, you have to address that obstruction, or if these kids, they may potentially need a dialysis eventually if it continues and it's not addressed. Okay, so you want to try to promote their max renal function that they can. Maintaining their fluid and electrolyte balances is one way that you can do that. These kids who have chronic renal failure, they're going to also have chronically low hemoglobin and hematocrit because of their erythropoietin being diminished. Okay, so they're going to potentially need erythropoietin given more often, or maybe even transfusions. Okay, with kids with renal failure, chronic renal failure, you're going to have to then treat any systemic complication from that chronic renal failure. And then try to have these kiddos have as normal and as active of life as possible. Okay, dialysis. So this is peritoneal dialysis that's showing in this picture. So this is the tube that goes into the peritoneal cavity, and then it works for the filtration. Okay, there's hemodialysis and hemofiltration as well. Okay, so most common method for kiddos is the peritoneal dialysis. So you won't see the venous dialysis ports like you see in adults. So this is a semi-permeable membrane that is inserted into the abdominal cavity. Okay, you put in a warm solution, it enters the abdominal cavity by gravity, and then it remains for a period of time, and then they remove it. Okay. Your biggest concern is peritonitis, so infection in that peritoneal cavity. So if there's any change in color of the fluid, then that is suggestive of infection, or if it looks more cloudy, then that could mean infection. So right away you would be calling the provider. Okay, and they'll be likely ordering antibiotics. Some of this can be managed at home, but sometimes they still have to come in and have official dialysis in the hospital or in an outpatient clinic setting. Okay, what best describes acute glomerular nephritis? A, it occurs often after a UTI. It occurs often after a strep infection, associated with renal vascular disorders, or associated with structural abnormalities.
B.
Yes. after strep. Glomerular nephritis is with strep. Okay, GI. Okay, nutritional disorders. So there can be vitamin imbalances, which is not uncommon based off of our typical American diets and typical childhood diets. These days, unfortunately, we're just not eating as many of the beneficial vitamins and minerals that are within food. So we're having a lot more nutritional disorders. With nutritional disorders, there's concerns for growth failure. Okay, so kids aren't going to get the nutrition that they need via vitamins and minerals. Then a lot of times you see their growth is affected. Further, so disorders that can cause nutritional disorders are things like cancer. So think about they're having chemotherapy, and cancer really wreaks havoc on the entire body. So a lot of times these kids have nutritional deficiencies. Kids with HIV, that's an immune dysfunction, immune deficiency. So these kids are also more likely to have nutritional disorders. Sickle cell disease kids, cystic fibrosis kids, and low birth weight kiddos. These kids are all at risk for vitamin imbalances. Specifically with cystic fibrosis, do we remember what types of vitamins these kids have to have?
Fat soluble.
Yep.
And K.
Yep. Good. Okay, celiac disease. So this is a gluten-sensitive enteropathy or celiac spirae. So this affects the small intestine. So instead of having these good lining, it's essentially they're not fully developed. So then you get this celiac disease. So this is what the inside of the healthy small intestine should look like, the cilia. And then with celiac disease, essentially the cilia are non-developed. Okay. With these kids, you're going to see steraturia, which is pale, bulky, malodorous stools. They're going to have overall malnutrition. So a lot of times they're not growing like they should. And then abdominal distension. And then, like we talked about in the Kahoot, these kids will also have vitamin deficiencies. Kids who have true celiac disease have to abide by a gluten-free diet. Okay. Usually management is nutritional management, so avoiding eating gluten. Okay. Rice can be a good alternative as well as nuts and seeds. Okay. But they cannot have wheat, rye, or barley. Good. Food allergy. So this is an immune response to an exposure of a given food. Okay, with food allergy, a lot of times you'll see rash, significant vomiting or diarrhea. Okay, obviously anaphylaxis. Okay, there's different kind of severities of rash or of food allergy. Okay, an intolerance would just be, these kiddos eat this food and then they have diarrhea, but it's not like nonstop diarrhea, significant vomiting. Okay. Common food allergy, especially in early infancy, is cow's milk protein allergy. So those kiddos have to do soy milk instead, usually. Or parents, if they're breastfeeding, they have to avoid dairy. Okay. What you'll see with cow's milk protein intolerance or allergy will be significant loose, mucousy, green stools, and a lot of times it'll have blood streaks in it. Okay. If they have low lactose intolerance or cow milk protein deficiency, then a lot of times they're going to have vitamin D and calcium deficits as well. So making sure that they're getting vitamin D and calcium supplementation. Okay. Any sort of GI dysfunction is going to cause growth failure. Potentially, a lot of times these kids are going to have vomiting, nausea, spitting up or GERD, constipation, diarrhea. These are all types of GI dysfunction. Dysphagia, so difficulty swallowing, difficulty eating, fever, jaundice. So jaundice, you get concerned about liver, which goes along with GI. So dehydration. So this is when there's total, your total output exceeds your intake. Okay, so that's the definition of dehydration. Okay. Potential causes of dehydration: burns. So if a kiddo has burns, you're going to be a lot more concerned about them getting dehydrated easily. Ketoacidosis. So if they're in DKA, they're more likely, because of their acidotic status, they're going to become dehydrated more quickly. Vomiting or diarrhea. That's kind of our classic dehydration for kids that we worry about. And then increased renal excretion, or, a fluid loss like trauma or something. So signs of dehydration in infants, the most common one is sunken fontanelle. You're going to see high heart rate, a low blood pressure. The blood pressure will be low later in dehydration. You'll see the heart rate start to elevate more quickly than the blood pressure lowering. Okay. Crying without tears, them having skin tinting, so increased turgor, decreased urinary output, and prolonged or increased capillary refill. So your management is going to be getting blood work to see where their electrolytes are with a BMP, and then replacing those fluids with either IV or PO options, depending on if they're having a lot of vomiting, then you're going to be doing IV. Okay. You are not putting any potassium chloride into the fluids until they have had a good urinary output. Okay. But in kids, a lot of times we have potassium chloride added to NS for fluids. Okay. But that is not added until they have had good urinary output. Okay. You will also be giving an antiemetic, most commonly Zofran, in these kids if they're having vomiting that's causing their dehydration. Okay. Making sure you get an accurate admission weight, and then you're getting daily weights on these kids with dehydration. Okay. So accurate INO, that includes anything that's going into or out of the patient. So measuring their vomiting, monitoring their sweating. So if they're having a lot of sweating, obviously they're losing fluid that way as well. Their urine and their stools, looking at their vital signs, their skin turgor, looking at their mucous membranes. Are they crying tears? Their fontanelle for infants. Okay. If they're having sensory alterations or level of consciousness changes for older kiddos, confusion. Okay. There's different types of diarrhea. So there's acute, which is typically an infectious form of diarrhea. Okay. And then there's chronic, which is usually diarrhea of infancy or chronic non-specified diarrhea. Okay. So with looking at management of diarrhea, your fluid and electrolyte, monitoring that balance. So these kids will be having most likely oral rehydration therapy unless they're having significant fluid loss with diarrhea. Okay. So usually you try to orally hydrate these kids first versus IV hydration. Okay. And then you want to slowly reintroduce diet. So you're going to start with, clear liquids and then full liquids and then you know, more bland foods, and then they can kind of go to their usual foods. Okay, not just straight to usual foods. Constipation, so this is an alteration in the frequency or consistency of the stools. Okay. So usually it's idiopathic or functional constipation, so we don't really know the cause. And then chronic constipation can occur when there's psychological factors potentially, or an environmental factor that these kiddos do not want to pass their stool. Okay. It's time that you guys can leave if you would like. I can continue for those of you that would like to continue with the PowerPoint. Have a good week. Remember, no class next week, but there are exam reviews, okay? See you later.
Thank you. Have
All
a good
right,
week.
see you.
Yep, see you later. Are you guys wanting to stay on? Yeah. Okay, I can stay on for like 10 more minutes, okay? Okay. So constipation during the newborn period, this would be not passing the meconium stool within the first 24 to 36 hours, okay? So if that's happening, then you get concerned of them having intestinal atresia or narrowing. So stenosis and atresia are similar. That's a narrowing, okay, of the intestines. Hirschsprung's disease or hypothyroidism can also cause delayed passage of the meconium stool, or a meconium ileus, which is common with cystic fibrosis. So if babies aren't passing meconium within the first 24 to 36 hours, you should be checking into those diagnoses. Constipation, it's really hard to know what is causing constipation in breastfed infants, because as they are digesting the breast milk, or as their GI tract is fully developing, they digest the breast milk a lot better than they do formula. So there's a lot of reduction in the frequency of stools that breastfed babies are having. Okay. So it's not uncommon for breastfed babies sometimes to go even 7 to 10 days without having a stool and not be extremely uncomfortable. Okay. So formula fed babies is where you more likely see the constipation. Usually it's from dairy based formulas. And if you change them to soy or Nutramigen or Alimentum, which have neither soy nor dairy, then these kiddos do better with their constipation. If they are eating or infants that you can feed, then adding things like whole grains or black beans or prunes can kind of help regulate their stools. Enterobiosis, so this is what a pinworm looks like. So when parents put that Scotch tape on their kiddo's bottom and they come out at night, then this is what you will see on the Scotch tape. So these kids are going to have significant anal itching, usually poor sleep. Like I said, they get it usually from going outside, digging in the dirt, and then putting their fingers in their mouth and the dirt continuing to be under their fingernails. So you want to keep these kiddos' nails short, not only for them to potentially collect less dirt, but so that way when they're itching their bottom, they're not causing, tears and things for other infections like staph or strep to get into those open wounds. So once this diagnosis is confirmed, there's anti-parasitic medication that these kids have to take. And actually it's over the counter now. Okay. Peptic ulcer disease, so PUD, this can be either acute or chronic depending on how long these ulcerations are continuing. Typically caused from increased gastric acid. So these kids are first given Zantac or ranitidine, an antacid medication to reduce their gastric acid production. And then if it continues, then they may need to have surgery. Okay. Usually with given the Zantac, the ulcers resolve. Okay, hepatic disorders. So there can be acute or chronic inflammation of the liver, which is hepatitis, okay? So hepatitis can be viral, it can be not viral. There can be like an obstruction of the hepatic, oh my gosh, ducts that are causing inflammation of the liver. It can be an autoimmune response. It can be from a metabolic reason. It can be from an unknown reason, so it can be idiopathic. Okay. Diets for kids who have hepatitis, no matter what the cause of hepatitis is, should be high protein and high carbs. Okay. Because these kids are going to have a lot of muscle wasting. Okay. And low fat. Okay. Because they're already struggling with abdominal distension because of their liver being inflamed. So you want to not further worsen that by having them have a lot of fat in their diet. Okay, let's see. So biliary atresia, this is extra hepatic biliary atresia. So this is where there's going to be a narrowing in the bile duct, and you're going to get a backup of bile then into the liver. Okay. So you can see the bile duct is narrow. Like I said, atresia or stenosis is that narrowing. And so then it's in the biliary tree, which tells you it's the bile duct. Okay. Usually it's an unknown reason. It's usually the kiddo seems healthy at birth, but then they just continue to be jaundice after birth. Never really improves. So this is diagnosed. They can have ultrasound scans done, and you can see that atresia. If it continues and it's not treated or not diagnosed, then these kids will have liver cirrhosis from the atresia itself. Usually they go in and they open that bile duct up and it should improve. Okay. Should we stop? Thanks for staying on with me.
You're welcome. Thank you.
Yep. Let me know if you guys need anything else or have any other